That's recording. Fantastic. Patient labeling, insufficient patient details. So when the not enough details of the patient is labeled onto the specimen itself, and any non-unique identifiers that are being used. The fourth step is the transport. So when the actual sample gets transported to the laboratory, some potential errors may include the delay in transport. So the sample not arriving in the laboratory at a fast enough window. Incorrect temperature of the sample storage. So whether something might need refrigeration and has not been refrigerated between the time of collection and it arriving at the laboratory. Sometimes some ice packs that are directly on samples can cause some cell lysis, and some damaging of the containers and packaging can also occur during transport. And lastly, the receipt. So some of the areas that might occur during this stage could be that urgent or stat specimens are not identified and therefore missing that turnaround time. High risk specimens, so things that could be very contagious, might be missed, and therefore, staff can't take that additional step to protect themselves. And also, specimen type is misidentified at triage. So, for example, if you had an urgent sample like a CSF being mixed with routine samples like urines. So this is just a rough overview of some transport requirements for different samples, and the temperature and the expected time it should arrive in the laboratory. So you can see here that depending on the different type of samples, you actually have different requirements that are needed for the sample to actually arrive in the lab itself. So you can see that sterile specimens such as CSFs have a much shorter turnaround time for it to reach the laboratory compared to some of the other ones, such as urines, which is within 24 hours. So some labeling requirements is often based on local guidelines. So hospitals and some laboratories will have their own guidelines, but at a minimum, there should be 2 patient identifiers. And this might look like a full name and a date of birth, or a full name and a unique identifier. So this unique identifier could be a hospital number, or something like this. A date and time of collection is also something that should be on the labels itself, and also the site of collection is not vital to have, but it's very, very useful when it reaches the laboratory. So now we are looking at some markers for specimen quality. So let's look at sputum. How can we assess the quality of sputum that we receive? So sputums are most frequently obtained for lower respiratory tract infection diagnosis, and it's often difficult to determine whether something is a pathogen due to the high degree of colonization in this sample type. To determine if a sample is of high quality, one can use a scoring system to determine whether the sample is useful for culture. So some exceptions to this would include sputums from immunocompromised patients, from pediatric patients, or maybe some cystic fibrosis patients, where it's difficult for them to actually bring up the sputum. An important thing to note is to have no food particles in these sputum samples. Has anyone heard of the Bartlett scoring system? So the Bartlett scoring system is a type of system that will assess whether there is a inflammation response. And what it's based on is from the gram stain. So some laboratories will do all the gram stains for all the sputums that come in, whether it's salivary or mucoid. And when they have a look at the actual sputum in the gram stain, they'll be able to score whether something is acceptable for culture or if it's unacceptable for culture. So how this system works is when you're looking at your gram stain at a low power field, if you can see that there are greater than 25 neutrophils, this will be a score of +2. If it's a 10 to 25 neutrophils in the lower power field, it'll be +1. And if there's less than 10, it'll be a score of 0. Then you will look at the epithelial cells. If there is an epithelial cell count between 10 to 25, that is a -1 point. And if it's greater than 25, it's -2. If there are presence of mucus strands, it's a score of +1. So when you add everything together, if your ending score is equal or greater than a score of 1, this will be acceptable and it indicates an active inflammation sample worthy of culture. If it's a score of less than 0 or equals to 0, it's unacceptable, and that would mean that it indicates a contamination with saliva. So this is an interesting scoring system. So some laboratories already do this. They might not have maybe like an official scoring system, but if something is overly salivary or it shows no presence of pus cells or neutrophils, then they might choose to not culture this. And it's really important to remember that to communicate all rejection of samples to the clinicians. Okay. The second one is urine quality. So the quality of urine collection directly impacts the end culture result. To ensure laboratories receive quality samples, collection centres should ensure there are clear instructions for patients so that they know what to expect when they're collecting the urine sample. Cleaning materials, it will be ideal for it to be provided, such as wet wipes, to provide for the patient's clean area before collection. Samples which are poorly collected will be determined by the presence of epithelial cells. So this is something that when we are reading our cultures or when we're actually doing the analysis, we can use this information to determine the quality of the urine sample that is collected. For blood culture, we want to ensure that there is aseptic technique. It's a crucial step and often where contamination occurs. And some sources of contamination can happen on the skin or even environmental factors as well. Another thing to note for the quality of a blood culture specimen would be the volume of blood collected. So depending on the patient and the type of blood cultures you're collecting, so for adult bottles, your anaerobic and aerobic bottles should have around 10 mils. For pediatric bottles is anywhere between 1 mil and 5 mils. And it's really important here to follow the manufacturer guidelines. So I know that in Cambodia, we sometimes have some blood culture bottles from other brands, so not necessarily like a BD, for example, and they could be in-house made bottles. If they're in-house made bottles, they might not follow this 10 mil or 1 to 5 mil for pediatrics. They will have their own guidelines. So it's very important that if you're using a in-house made blood culture bottle, to follow these guidelines. Um, Another thing to determine the quality is the number of bottles collected. So for an adult, it's ideal to collect 2 bottles, an aerobic bottle and an anaerobic bottle. Whereas pediatric patients, if you can, an anaerobic bottle in addition to the pediatric bottle would be fantastic, but sometimes babies, they don't have that much blood, so a pediatric bottle is fine. And the last thing to note is the rapid transport. So the faster these blood cultures can get into an incubator, the faster the turnaround time for positive or negative result. Then we're talking about wound and tissue specimens. So this is quite important to talk about sampling technique. So with things like your swabs, it's a representation of what is collected on the wound itself. So ideally, pus samples or tissue samples are sent instead, but in the absence of those, or if we can't collect those, a swab will do okay. They're acceptable, but they have low sensitivity. So what we want to do is swab areas with visible sores, so have some material to actually be on the swab itself. So things like blood or pus or some crusty areas around the sores would be good. The wound site and type is important for culture interpretation. So before we were talking about labeling, sample labeling, and actually putting down where the site of the specimen is coming from, this is incredibly important when we are looking at interpreting our cultures. So when we are collecting our wound swabs, adding this site will be very, very useful. This is because we want to understand what is potentially pathogenic in that specimen site or what is considered normal flora. And then the last point is to use appropriate media. So, for example, amines gel for fastidious organisms or things such as anaerobes. Because as you can imagine, if you have a dry swab without any media, if there were any anaerobes present, they will likely die due to being exposed to air and whatnot. Okay, now we talk about CSF and other sterile sites. So these specimens are almost, I should probably fix that, but almost never rejected. And this is because they are likely to be difficult to obtain. And there'll be a bit more information about some exceptions to this rejection criteria rules. These, if multiple tubes are received, microscopy is always performed on the final tube because this is likely to be the least contaminated. It's free from trauma tap, which might happen when we first start collecting a sample. There might be a lot of blood in it, and it's likely to represent the site of infection. Feces, depending on the test, there are different requirements. So I could give in 3 key examples. So for stool culture, generally any collection of stool seems to be okay for the culture itself. But if we're looking for specific pathogens, there are often certain requirements that we need, like an additional container, for example. So for Clostridium difficile, testing usually requires an unformed watery sample. So if it's a formed stool, it's likely to be rejected due to the likelihood of it being positive for Clostridium difficile. Oocyst and parasite detection would need an additional sample in a fixative to preserve the parasites if they are present. So this could be an additional pot of the feces in a SAF fixative to create a concentrate. Some additional clinical notes or details, such as someone being an overseas traveller or having chronic diarrhea. This could be a hint to do additional testing for feces culture. So now we're talking about specimen rejection criteria. So what is the actual criteria to reject samples and what do we do? So for general rejection criteria, anything that's unlabeled or mislabeled should probably be rejected unless that is one of the exemptions that we'll speak about later. If a container is leaking, broken, or you can see visibly that it's been contaminated, this should also be rejected. Incorrect container type for the test ordered. So this really depends on what type of test and what sample we're talking about. If it's going to be, for example, a CSF collected in a fecal pot, this is something that we will probably reject because fecal pots are not sterile, they're just clean. But if it was a CSF that was collected in a urine pot, which is sterile, then we can potentially accept it. So it depends on the specimen type and what container it's being received in. Whether the volume is insufficient for testing. So again, depending on what type of test, for example, if you have a urine sample that has come in with minimal volume, if it's only enough for culture or only enough for microscopy, this is a different, like the lab will have to discuss with the report clinician and decide which test they would like and reject the one that's not enough sample to do. Duplicate specimens within a defined hold-off period. So if in your laboratory you have a strict rule that says if you have a positive sputum sample that is growing Pseudomonas, if you decide to collect another sputum within 2 days, the second sputum will be rejected because the patient likely still has the Pseudomonas. So these are all predefined criteria that are unique to each lab and hospital. So if you have something like that in place, it's important to reject the other ones and explain why. If something doesn't have a request form or is missing clinical details, that is another reason you might have to reject a test or at least call the clinician to see what the test is. And lastly, the specimen type and the test ordered is incompatible. So for example, if you received a urine and they asked for a blood culture request instead. So what is the rejection process? So the first one is the specimen is received. We want to assess whether the sample has been received with the correct paperwork or the number of samples per request. We then want to assess the criteria. So whether the collection is in the correct storage and whether it meets the correct transport requirements or if individual sample requirements were met. You would want to reject it if it doesn't meet any of these criteria. If the sample is not meeting testing criteria, it can be rejected as per local guidelines, particularly if they're not considered a precious sample. So, what do we mean by a precious sample? So, exemptions that we're talking about, any precious or irreplaceable samples cannot, so if anything that cannot be recollected or will be difficult to recollect, such as CSFs or tissues or post-mortem samples, these we might exempt for them from particular rejections. So every time we are thinking about rejecting a sample, we would call up the requesting clinician to see if anything can be done. So, for example, if a CSF was mislabeled with mismatching patient details to the request form, you would call the clinician who perhaps, hopefully, had performed the lumbar puncture and to either ask them to re-sign or advocate that this sample had come out of patient A and not patient B as labeled, or something like this to prevent the patient from repeating the lumbar puncture. Things like post-mortem samples are obviously difficult to recollect as the patient's passed away. So again, this would need to be worked around with the clinician. Immunocompromised patients, perhaps that there might be like a sample that can't be recollected due to the situation. Pediatric patients as well, that will fall under there. Any critical samples, so for example, if the patient is on the surgical operating room and they're waiting for urgent ground stain and they can't recollect it for whatever reason. So there are specific exemptions, but the laboratory needs to work through these exemptions with the treating clinician and ideally have a protocol in place so that when things do happen, there is a strict protocol that the laboratory can follow. So the fourth step is to notify the requester. So notify the requesting clinician or ward as per local guidelines, ensure to request a recollection if clinically indicated. So how do we communicate the rejections? We want to communicate the rejection in a timely, clear, and non-judgmental communication. So what I mean by non-judgmental, we don't want to tell the doctor or the wards that they're wrong and they need to recollect because what they've done is incorrect and blah, blah, blah. You need to communicate it in a clear manner so they understand that this is what's happened. It needs to be rectified by following A, B, and C steps and whether they would like to recollect or not. So you must, you must include reasons for the rejection and any guidance for recollection. So, for example, if you were rejecting a feces sample because it is formed and it was being requested for a Clostridium difficile test that requires an unformed stool sample, you can reject it and say that we're not doing this because it's a formed stool. If the patient happens to show signs of like diarrhea or starts to experience unformed stools, then you can recollect that to submit for that same test. So methods for communication, you can have verbal notification for more urgent and critical specimens. You can have a laboratory information system generated rejection notices. So for example, per each test that you sample you receive, actual report should go out and the communication can go out with that same report. And that's what the last dot point is. We want to then document the rejection. So document the sample rejection with why the sample was received, who was notified, and whether something will be recollected. And this is extremely important because all these sample rejections should feed into continuing education. So we must ensure that there is a view, either quarterly, biannually, or annual, of sample rejections because this way we can use this data to offer educational sessions on sample collection requirements. So what does this continuing education look like? So this is the direct feedback to the clinic and ward staff immediately after the rejection, but all rejections must be logged with the reason, time, and the staff notified. Once we review the sample rejection data, we can identify the frequency by the laboratory protocol. So how frequent are these samples being rejected? Any key wards or clinics which have a high rate of rejections. You can identify key samples that are being rejected. You can also use the rejection criteria to drive some pre-collection education. So with this data, if you can see that there is a ward that is struggling with collecting the appropriate samples, that ward can be targeted for re-education. And therefore we can start seeing any improvements after this education. And if it doesn't, is there an underlying thing? Are they running out of containers? Do they find it difficult to collect the sample itself? This is how you can start identifying where those key issues are. So we can create resources for information sharing, for example, a specimen collection handbook. And I know that NIPH have been looking into something like this. And also to run hospital-wide seminars if there are key samples, for example, that are difficult to collect or a procedure that's difficult to follow. So what are the key summaries and takeaways of this session? The first one is that it's a shared responsibility. Specimen quality is a shared responsibility between the lab and also clinical teams. The purpose of rejection criteria is to protect patients from misdiagnosis. Communicate with the clinical team. And I think this is really important. I know that there's some clinicians that have joined this session today, which is great, but we must communicate and understand why sample collection is not meeting the criteria. Document communications. All sample rejections must be documented with fine details. And lastly, provide feedback and training. Feedback sample rejections to primary collectors and also the requesting clinicians. So altogether, this whole wheel will ensure that sample quality is good, the pre-analytical step of the process is good, then your actual testing of the specimens can produce better results because the quality of the samples have improved as well. And so that brings us to the end of this session. Now we have a breakout room activity. So before we continue with this activity, are there any key questions about what we've just spoken about?
បាទអញ្ចឹងសូមជំរាបសួរលោកគ្រូអ្នកគ្រូម្ដងទៀតហើយឥឡូវនេះយើងខៃលីគាត់បាន present រួចរាល់ហើយយើងនឹងមាន breakout room activity ហើយមុននឹងយើងចាប់ផ្ដើមកម្មវិធីហ្នឹងសូមអនុញ្ញាតលោកគ្រូអ្នកគ្រូដែលមានសំណួរអាចលើកជាសំណួរបានណាអរគុណច្រើន
Okay, maybe there isn't, but that's okay. So there'll be an opportunity to ask later on. So for the breakout room activity, there'll be a few discussion points. So you will be assigned to a breakout room with some of the other networks or practice members. And these are the few discussion points that I want you to talk about. The first one is there any key sample types that are likely to be rejected by your laboratory? Are there currently any communication pathways to notify sample rejection? Any key specimen collection issues that the laboratory is currently facing? And any continuing education planned for hospital staff surrounding this type of training? So I'll split you off into different breakout rooms and we will meet back in around 10 minutes.
បាទអញ្ចឹងលោកគ្រូអ្នកគ្រូទាំងអស់គ្នានឹងត្រូវបាន assign ដើម្បីចូលទៅ breakout room ទៅតាមកន្លែងនីមួយៗសូមលោកគ្រូអ្នកគ្រូjoinផងហើយយើងនឹងធ្វើការពិភាក្សាទៅតាមអ្វីដែលយើងបានលើកឡើងនេះដោយនៅខៃលីក៏បានលើកឡើងចំនួន4ចំណុចនេះហើយយើងនឹងពិភាក្សាគ្នារយៈពេល10នាទីហើយយើងនឹងមកជួបជុំគ្នាវិញបាទ
Okay, great. Thank you, Vandrith. It would be worthwhile to take a screenshot of these questions so that you can discuss them with your group. Okay, great. I'm going to put you guys in breakout rooms now. Vandrith, I went through all the different breakout rooms, but I saw that your room was consistently always in discussion, so I just left you.
Okay, actually we have a lot of discussion from mostly we have three hospital, but one hospital he is a doctor, but team so he doesn't have much experience in the laboratory. So we have another two hospital in the laboratory. So maybe we have a lot of feedback. Yes.
And I think that's excellent. And, you know, sometimes doctors don't have that feedback from what the lab rejects, but they get the rejection emails, or they then check the report later on and then realize that, oh, the test hasn't been done because it's been rejected. So I think both ends are very important. So it'll be interesting to see what's the feedback or what thoughts that the doctors have as well. Okay, so I think some people are still in the breakout rooms. Just let me quickly have a look. Everyone should be coming back soon.
Maybe inform in the group.
Yes. I think all Terry's back. Okay. I think maybe everyone's back. I think maybe some people left thinking it was the last thing that we were doing today. So that's okay. I think now.
Yeah, so I think that we can start from group one first, the breaking.
Yeah, sorry. Yep. This might be just a little bit easier because I think. Okay. All right. Does everyone know what group they were in? Probably. It's okay. I have a list. So. Okay. So
you want what you?
Yep.
What you gonna do?
Yep. So room one was Vanderith, Dr. Sokchan, there was Shranich, Singh and Sona. Am I saying this right?
So do you want one of them to report back or what?
Yep. Anyone can report back in from group one. So what are some?
Let me speak in Khmer to my team a little bit.
Yep.
So ចឹងបងសុកច័ន្ទឬក៏អ្នកគ្រូសូណាគាត់អាច report back ឬក៏មិនបងសុកច័ន្ទបងសូណា
សូមឲ្យលោកគ្រូសុចាន់គាត់អ្នក report ទៅព្រោះគាត់អ្នក record ហ្នឹងគាត់អ្នកគាត់ទៅគាត់ report តាក់ទងនឹងអ្វីដែលយើងនិយាយមិញទៅចាមិនដឹងលោកគ្រូសុចាន់សូម
បាទអត់អីខ្ញុំគាត់តែខ្វះអីចាំអ្នកគ្រូដែលមានយល់បន្ថែមទៅតែលោកគាត់ទៅមានខ្វះមានអីចឹងភាសាចាខាងนั้นដែរ
Okay, so Dr. Sokchan will be report and Dr. Savannah will add something for the missing key discussion. Thank you.
That's great. Thank you. Is it possible if I get everyone to turn on their cameras when they're speaking so I can start putting names to faces? I know what Dr. Sokchan looks like, so that's okay. But I'm not sure who Dr. Sona is, so it'll be good.
I'm not doctor, I'm a lab technician. So yeah. Okay.
Actually, Kylie want to see your fan.
Okay.
Yeah, perfect. Hello, I've seen you before. Yep. Hello.
Hello. Yes.
She's so pretty.
Yes. You're from Sam Reap Lab? From the Sam Reap Lab?
Uncle Hospital for Children.
Yep.
Uncle Hospital for Children.
Yeah, that's right. Okay, great. So, what are some key sample types that are likely to be rejected?
So I start to report from the key sample type that we are likely rejected. So in my team that have some idea, yes, the most frequency specimen that rejected is from non-sterile site like urine, stool. That the reason that collects is from the caretaker collected due to from Uncle Hospital for Children is the patient is children, so the caretaker family is collected. And the less frequency sterile site such as blood sometimes have from label. and from the Takeo Hospital, mostly from sputum that has none quality. That's all.
Yeah. So blood cultures are not going to be rejected. And then was it also sputum samples would be rejected as well? No.
ចឹងបងអត់ sputum មិនដែរបងគេreject អត់បង
សុំអ្នកគ្រូខាងតាកែវគាត់ដូចជា reject sputum ដែរបើសិនជាកាលណាគាត់ឃើញ epithelial cell ច្រើនទៅគាត់ reject ហ្នឹងអ្វីដែលគាត់និយាយបែបហ្នឹងតែ
បងអាចនិយាយអង់គ្លេសហ្មងបង
Yes, and for the sputum for culture, if the epithelial cell is higher than greater than 10 kilopascal, we reject the specimen and request the new one.
Yeah, excellent. So that's what we spoke about in the presentation earlier with the Bartlett system. If it's over greater than a certain amount, then we will not perform it. So that's good. And what about catheter specimens? Catheter, like what key things are we looking at here?
catheter specimen
Yeah. So do we reject catheter specimens?
ខ្ញុំសូមនិយាយលោកគ្រូ catheter specimen ដូចយើងអត់បាន include ទៅក្នុងហ្នឹងឯងយើងនិយាយរឿង blood culture specimen ទេមែនទេ
Yeah, actually in our team we didn't discuss about catheter specimen. We just talk about the blood culture.
Okay, no worries. Yeah, so not rejecting blood cultures.
Blood culture we will reject if we contact to the clinician first, like if the clinician could not provide more information regarding the specimen, like it's not matching the like if they provide on the border label on the border of the patient is not correct with the requesting, we would require, but we should wait like for 1 day before we destroy the specimen. So we contact to the clinician first. If the clinician provide more good information, so we would process.
Yeah. Okay, that sounds great.
Yeah.
Perfect. All right, thank you, group 1. So we have some non-sterile sites, some urine, stools, sputum samples that have high epithelial cells, and blood culture samples as well. Okay, great, thank you. What about group 3? And just in case it's silent, it's Pateri, Rexa, and Bullock.
Okay, thank you, Penny. My group have 2 discussion look like similar to group 1. The key that's important is the urine and stool and sputum also. And the reason that we have to reject this for urine culture in the cause that the physician and the doctor have to collect more than 20 hours. We can reject this one. And the last at another side, when we know if the result for the culture is the micro or contamination, we can also have the doctor or nursing to recollect again. And for the stool culture, I think Pateri will talk about this. So if she want to add any information, you can add, Terry.
Yeah, Terry, up to you.
Hello.
Hello.
No, I know my laboratory only to receive stool culture, but I reject. I some reject for stool culture, but not only to reject because 1 month we receive only 1 stool sample. So what I say to reject is stool culture is we culture only diarrhea diarrhea or something, but when the clinician culture the stool, mostly stool is not diarrhea.
Yeah.
Yeah, just being
Yep.
hard. So we
Yep.
reject. Yes. Other than stool hard, we reject it.
Yep.
Yeah, something like that.
No, that's good. Thank you. Anything else that you want to add for group 3?
Our group, no.
Nope, all good. Perfect. And then the last group, which is group 4. So that's Vidika, Ratha, and Yan.
Good afternoon, everyone. My name is Ratha from Central Hospital Center Hope, representing of my group 4. Similar to other group, I just add another one urine sample that's leakage. We also rejected and no labeling. In rare case, another one is swab or bacterial culture collected in wrong solution that we found it from operating room. No physician put it in the wrong container and add formalin solution in the sample. We also rejected. For the curation and solution, current practice after we got the sample that rejected, we notify to ordering physician or nurse to recollect sample and record in pre-analytical record form for documentation. I cannot hear you, Kelly.
Could you
Sorry, thank you. Yeah, no, I fall victim to that sometimes. So with that one, that's okay. So Ratha, I might stop you there for now. I think with the communication and things like that, that'll come with the other questions. Is there anything else that you want to talk about, plus any key sample types that are likely to be rejected, or some key reasons that might happen? So I think that we've got a pretty good list of some key reasons and solutions as to why that these samples are being rejected. Do you think that we have any solutions? So is there any solutions for those? I know that before it was mentioned that, for blood cultures, for example, we hold them for 24 hours, and then if the doctor would like to relabel or can vouch that this sample did come from this patient, then we will then process it. So that's somewhat of a solution. With the urine ones, the ones that are coming after 24 hours, is there any solution to this that we can think of?
We suggest that to recollect again for the but we have to provide some instruction for the nursing or for the physician to know how to the right collect for the urine culture. And also we can tell them to collect in the morning.
Yeah.
And how to clean before to collect the urine.
Yeah. Okay, great. Any other solutions that people can think of to help any of these issues? Are these issues that happen across all the laboratories? Give me a thumbs up if yes, and give me a thumbs down if no. Yep. So Ratha thinks so, Sana thinks so. Okay, so everyone's on the same page that, sometimes these things will happen, but how can we fix this? That is the key thing. So let's come back to the solutions part. So it's good that, communication is happening across some laboratories to do some recollections and give them some hints and tips as well. Okay, so the next question is, are there any communication pathways to notify sample rejection? So how are we telling our collectors that something is being rejected? So I've heard across some of the groups that we do phone calls. how else are we communicating some of these rejections? Free for anyone. Anyone can see. Don't be shy. Otherwise, I'll start asking each group again.
For our processing in an IPA, like microlab, we have to communicate with the OPD lab because the OPD lab who responsible for register and also receiving and reject the sample from the another lab. And then when the OPD lab to get information from microbiology lab, they can inform to the customer by verbal. Also, we can put the email. In case from the referral lab have to MOU, we have to contact so that we have to information by phone call, telegram, book, and email.
Yeah, that's great. So there's 3 solid communication pathways. Anyone else have other means to communicate these results to the clinicians? So we have phone calls, we have email, we have Telegram group. Is there any other ways to communicate that a sample has been rejected?
For me, I think one more thing, but I'm not sure it's correct or not.
That's okay.
We can inform by the result after we have to culture.
Yeah.
And we can comment in the result of the patient.
Okay, great. I think that looks pretty good. Vidika?
Actually,
I'm
another
just
one is
thinking that what senior is talking is probably very applicable for the sputum culture. Then we have to list down what we saw in the gram stain.
Yeah, I think
The reason,
yeah, I think what Rex has suggested is actually quite good for all sample types. So if we, for example, the sputum, if let's say I forgot who's mentioned this now, sorry, but for example, the sputum cultures, if we have to read the gram stains to determine how much epithelial cells were in the specimen itself, you would have some type of result already. So if you're doing the gram stain, you'll have all your gram stain results, and then in the comments, when you decide that you are not culturing this sputum sample, you'll have it in the comments, this sputum was inappropriate for culture or something like that. Yeah. Does that answer your query?
that was that was what I was thinking. But I couldn't put in from that.
That's okay. But yeah, you're on the right track. So you can be used for many different samples. It just depends on what information you want to convey.
So I guess the sample would be like urine process, and we also determine the acceptability by microscopic examination.
Yeah, exactly. Cool. Any other communication pathways you can think of, Vitika?
That's all.
That's all? Okay, no worries. Yeah, I think Ratha also wanted to say something.
Yes, correct. For the hospital, we have another way is work directly to ward or meet doctor to communicate or discuss about sample type and the rejection.
Yeah, what method would that be?
We work or we go directly to.
Oh, go directly.
Work.
Yeah.
Yeah, directly.
Okay. Yeah.
Because sometimes phone call or another cannot contacting or we have problem. When we face to face, more easier for communicating and solve the problem as well.
Yeah, and it's good because they can't run away. So that's good. Okay,
Somehow
great.
that sounds scary. That sounds scary. Like if you cannot collect it, let me do it. Let me show you how.
I think that's a very efficient way, and I think they can't.
Because
They
it's
can't.
current practice in my hospital is a small hospital. That's why it be easy to go through and meet face to face for communication.
Yeah, I think that's great. They definitely will think twice before doing it again, so that's good. Okay, great. I think that this is a very good list. Is there any room for improvement? So we know that phone calls and emails, Telegram groups, these are good. But is there any improvements that you feel like this type of structure needs? Does it need a bit more structure? Does it need a bit more hands-on? So, for example, the face-to-face, Ratha's just spoken about how good that could be, because when you see people face-to-face, they're forced to really listen to you. So, is there any improvements that we want to see in this process?
Maybe I want your question how to improve suggestion is mean improve the communication.
Or how do you want to improve the communication of these rejections to the clinicians or to the ward? So, for example, a good example would be a template. So, a template, like an email template. So, an email template for sending an email would be, specific key information that the laboratory needs to fill in to send to the ward or to the OPD lab or wherever. So this will ensure that the correct information is relayed to the collector. And this could be also like a phone script. So a phone script, you could have prompts for the person. So for example, if I'm calling from Cossack Hospital and then I forget what to say next, there's a script that we can read and then we can tell them, okay, well, this is what's being rejected. This is why we're rejecting it. If you need to recollect, do it this way. So this way, the information can always be the same every single time someone calls. So these are potential improvements that laboratories can adopt. Is there any other improvements that you want to see in this communication? Or are we all happy? Yeah, Rexa?
For me, I think that because for our working place, we have two SOP communication, so that our staff have to know how to communication with the physician or customer when we have any issue.
Yeah.
And also that they have to know the processing, and then we have to train for the staff how to communicate it.
Yeah, I think communication is also a key skill. So if you think that I think an SOP might be useful for someone who's new to the lab, but I think something like a job aid, which is quick to read, might be a lot more impactful because it doesn't take you a very long time to read the job aid. It's quite quick. So that might be something that we can think of as well. All right, great. Anything else that people want to see some improvements in, or are we quite happy with how we are approaching our communication? Okay, well, I'll let you think more about it. We'll go to the next question because we're running out of time. Okay, are there any key specimen collection issues that the laboratory is currently facing? So we know about our sample types, but is there something that keeps coming up? So, for example, for blood cultures, the collectors are constantly underfilling the blood culture bottles. Or is there constantly food particles in sputum samples? Anything from group 1?
Group 1?
Yep, anything that, I think this might be a bit difficult for you to answer, Dr. Sokchan, but is there anyone else from group 1, any key specimen collection issues that we see?
according we discussion in team, yes, the sample is not good quality, it might grow, and labeling not smart with the specimen container with the requestion form is not matching. Yes, and our sample collection size is not matching with the diagnosis.
Yeah.
And they may have some patient ID not full information.
Yeah.
Yes.
Okay. Yeah. Great.
One more is occasionally leaking, specimen leaking as well.
Specimen leaking, yeah. Yeah. Good. Fantastic. Okay. Anything else from group 1 or group 3 or group 4? Group 3 and 4, anything that you would like to add to this? There's only 4 more minutes.
Delay in sample transportation, especially the urine culture.
And also one more thing, clearly related to the culture non-grow. But when we see the bone, we see the material. So we expect that the patient have to take antibiotic.
Yeah, that's a good one. Specimen. I think sometimes that is inevitable, but this is something good to note. Okay, great. And then can we think of any improvements? How do we improve all this? How do we fix these labeling issues, request forms? How do we fix all these?
I think we have refresher trainings. Like we can keep this one as a quality indicator in our labs and to check every month if the specimen rejection is increased due to something. So we will inform to the clinician, to the clinical microbiology to refresh to the clinician.
Yeah. So some labs don't have a clinical microbiologist, but I think this will also be good for maybe like the ward heads to know about as well, or like the head of the lab or head of departments. Yeah.
And I think that we have to provide a job ad for the ward for the nursing how to collect the sample. I think that the job ad the collect specimen one by one, like save app, blood capture, like this.
Yeah, I think that's a good idea as well. All right, good. Anything else that we would like to add to the improvement list? Okay, no. All right, and this is the final question. Are we having any continuing education plans for the hospital staff? So before there was some improvements that we suggested, so things like job aids, some your refresher training. Is this something that's currently being done in any of the hospitals?
For our lab, we have to schedule out the plan on the training.
Yeah.
For one time per year.
Yeah. Is this for the collectors or for the lab staff, Rexa?
The lab staff we have also, and also the customer.
Yeah. Yeah. So NRPH is working on a workshop for the customers, which is good. Anyone else? Any of the other hospitals doing any education for their staff? Or the hospital staff? Okay, I'll take that as a no, but that's okay. Can you think of any methods that will be most impactful for your setting or for your hospital? So we have things like seminars or workshops. We spoke about job aids. Is there anything else that would be useful?
I think we have to conduct competency, maybe we have to supervision understand it. Yeah.
So this one might be a little bit tricky because this might fall outside the jurisdiction for the laboratory, and it will be more the ward side. So I think the head of the departments will have to have a play in this in order to conduct some of this competency assessments. Is there anything else that will be impactful to improve the situation? There really is no right or wrong answer, but the idea in this exercise is to identify if there are key issues in the laboratory with specimens and how can we overcome this. So I think in today's exercise there has been a lot of useful discussion about what happens in one person's lab is likely to happen at someone else's and how we can overcome these potential things. So this is the idea of having these discussions, is that there is no right or wrong answer, but there are a lot of solutions that we're potentially already exercising in some of the sentinel sites compared to others. Okay, good. All right. Well, it looks like there could be some impactful education sessions, so things like workshops, job aids, and maybe competency assessments. Is there anything else that we would like to add to this list?
I think we have like micro guide that everyone can staff in a hospital can access it. It would be easy. Yeah.
So, a micro guide. Yep, I think that's good. So something like a specimen collection handbook. Yeah, I think that'll be good. All right, great. If there is nothing else to add, the final part of this whole networks of practice session is a question and answer. So is there any questions? I know that it's been a very long session and a few of you have dropped off already, but is there any questions that you have for this session?
Currently, we have the specimen rejection criteria, but if like the doctor or like the clinician still want to do it, so we should have like the process it, but we should have like another comment to edit in the specimen as well. So yeah, I think would be, because sometimes we cannot like we reject it, but specimen is poor quality, but the doctor is still want us to process it, so we should process, but with the common caution as well.
Yep. Okay, good. I think I'll put that one in there as well. So some guided comments. Guided comments on reports. I think that's a good one as well. Yeah, so I think it was Ratha who spoke about tissues being received in formalin. So I agree. I think most times we would actually think about rejecting them, but there are odd times when the tissue sample is too precious to reject. So we would continue to culture them and put in a comment that says something like specimen received in an unsuitable container. The microbiologist, please interpret results with caution or something like this. So I agree, Sona, this is something that we would do in our labs as well, that if the clinician or the nature of the sample can't be replaced, we would still go ahead with culture, but put in a comment to just guide that interpretation a little bit. And this is also a form of education. That's good. Okay, great. Any other questions or comments from anyone before we close off today?
លោកគ្រូអ្នកគ្រូមានសំណួរអីបន្ថែមទេបាទ I think that is
Yes, from Dr. Sai, I think we should provide the SOP or job ad to on board, yes, for reuse the specimen rejection. Anyway, from the specimen rejection, I think from clinician or collection staff, he has some challenge also, especially the patient. Yeah, the patient when we suggest or request to redo again, sometimes he don't permit
patient's side that the laboratory doesn't see. So in the laboratory, we don't see patients and we only see the patient samples. And although it's frustrating sometimes, it's really important to understand and realize that at the end of the day, this sample comes from a patient. And I think this is where having doctors join the laboratory practice is it's very good because it gives us a different insight of what that side of the story is. So thank you, Dr. Sokchan. That was very good. Great. Any other comments from anyone else? All right, fantastic. I think that was an excellent second session for the laboratory practice. I will upload the recording and also the presentations and also our activities on our resource platform. Yeah, so if there's nothing that anyone else would like to discuss today, I'll bring this session to a close. Thank you.
ចឹងមុនពេលបញ្ចប់ខ្ញុំសូមអរគុណលោកគ្រូអ្នកគ្រូទាំងអស់គ្នាដែលបានចូលរួមនៅក្នុង session ថ្ងៃនេះហើយគ្រប់ material របស់យើងទាំងអស់នឹងការពិភាក្សាអីហ្នឹងយើងនឹង upload ចូលទៅក្នុង system របស់យើងនឹង alert ប្រាប់លោកគ្រូអ្នកគ្រូម្ដងទៀតអំពី system របស់យើងចឹងណាចឹងលោកគ្រូអ្នកគ្រូអាចចូលដើម្បីទៅ download បានចឹងអរគុណច្រើនហើយយើងសង្ឃឹមថាជួបគ្នានៅខែក្រោយនៅលើ topic training ផ្សេងទៀតបាទយើងនឹងជម្រាបលោកគ្រូអ្នកគ្រូមុនចឹងអរគុណលោកគ្រូអ្នកគ្រូទាំងអស់គ្នាសូមជម្រាបលាអរគុណច្រើនបាទ Thank you Kali Asra. Bye bye. Have a good day.